Welcome all. Um, I am Dr. Gaurav, and this is my colleague Dr. Anshu Mahajan. And next 1.5 to 2 hours, we're gonna take you through some of the cases, challenges, indications, contraindications of carotid stenting. As you can see, there are some flow models in the room also. So post talks and discussions, if you want, you are interested, you are free to play on them, learn on them. There are certain devices which are there, so feel free to take part in them. For now, what we're gonna do, Dr. Anshu is gonna start with basics of carotid stenting, indications, how we should approach the patients, and in the second half, I'm gonna cover more complex cases as you start doing your practice. And let's make it interactive. Feel free to ask questions, and depending on what you want to stress more, we can stop, discuss, and take it forward. So I think let's start with Dr. Anshu.
So, good evening, everyone. So, I'll begin the session and discuss. I'll be discussing on the patient preparation and I'll be discussing on the patient preparation and the hardware selection for the carotid artery stenting. So, slide. So, the most important question is why do we need to address the carotid artery disease? So, why it's so important? So, obviously, we know that it's a leading cause of morbidity and mortality, but we should also understand that every symptomatic stenosis was once an asymptomatic stenosis, and not all the strokes because of the stenosis presented with a warning sign, and most of the patients who have a larger stroke, they can't be always turned up even with the best medical IVTPA or the mechanical thrombectomy. So overall it is better to prevent rather than to treat the disease. So this is a very good example of a patient who presented to us in an OPD with a tight stenosis of right ICA. It was an asymptomatic stenosis. So he refused the treatment and he took discharge with the best medical management. So he was discharged with the dual antiplatelet drugs and high dose statins. This was the CT angiogram. There's a tight stenosis on the right ICA, and this is a intracranial circulation was normal. So it was done in January 2016. So within less than a month period, this patient presented to us in an emergency with a left-sided weakness and facial deviation towards the left side. And we did an MRI which showed a large infarct, established infarct in the right MCA territory. We can see that, and hardly any penumbra left. And we can see that the ICA is not ICA is occluded, and the MCA is not seen here. So it was a complete occlusion of the right side circulation. So patient had got huge infarct. So no penumbra was left. So that lies the importance of prevention. It is better to be very aggressive to deal with these kind of lesions. So these are the guidelines which were established in 2014, which was laid down by the AHA, and which say that more than 80% asymptomatic stenosis they are to be dealt, and in case of symptomatic stenosis, if they are more than 50% on the DSA, it should be dealt at aggressively. So these are the recent guidelines, which says that in a patient with a TIE and non-disabling ischemic stroke, within the past 6 months, the CE or CES is recommended with a periprocedural risk and mortality rate of less than 6%. So decision is more based on the patient comorbidities and vascular anatomy also. So how do we approach the carotid revascularization? First of all, we need to have a good patient preparation. So we need to have a good clinical history, neurological examination. The previous imaging is needed to be evaluated, on the basis of which we can plan the carotid stenting. The current medications, we have to evaluate any anticoagulation or antiplatelet agents the patient is on, and the detailed cardiology review is required. The PAC, pre-anesthetic checkup, is required, and if there is an allergic history, the prophylaxis is required before the procedure, because we had to use the dye in these patients. And then the most important is the consent for the procedure, and we also ask for the routine laboratory investigations. So, first of all, the imaging evaluation of the carotid is very important to plan the carotid stenting. So, carotid duplex or the carotid duplex is a basic screening procedure. It actually detects the focal increase in the blood flow velocity. So, it has a sensitivity of 80 to 90%. So another investigation is the CT angiography. It has an additional advantage. It depicts the arch morphology better, and it also depicts the lumen and the wall of the carotid artery. And the 3D reconstruction pictures actually provides the accurate diameter of the residual lumen. So, like in this case, we can see that the arch is bovine. We can plan this case with the SIM catheter, which is a reverse shape catheter. And on the axial anatomy, we can also see that there is a floating clot. And this is a 3D reconstruction image. We can exactly quantify the degree of the stenosis. So, MR angiography is another alternative, but it actually overestimates the stenosis in cases of mild to moderate cases, but it is more accurate in cases of tight stenosis. So, as we know that the distal subtraction angiography is a gold standard test, it actually depicts the lumen, it actually depicts the exact degree of the stenosis, and we can better plan the carotid artery stenting on the DSA images. So there are three criteria on the basis of which we can measure the degree of stenosis in the diseased carotid artery. One is the NACET criteria, one is the ECST criteria, and other is the CCA criteria. The most commonly used is the NACET criteria. So NACET criteria is so that we calculate the degree of stenosis by this formula: 1 minus A. A is the narrowest diameter of the stenosis, and divided by C. C is the normal distal cervical artery diameter, which is then actually calculates the exact degree of the stenosis. So previously there are many randomized trial which actually targeting the symptomatic and asymptomatic patients. They found no significant difference in terms of the safety and efficacy of this procedure. However, most of the trials which were targeting the symptomatic, they are more favoring the CEA as compared to the CAS, that is the carotid artery stenting, and they found more stroke after the stenting and more MI after the surgery in the peri-procedural period. This is a recent ACST trial which showed actually there was no significant difference in the complication rate between the CAS and CEA. So if you ask me what are the absolute indication of the carotid artery stenting, it is basically in a contraindication. Basically the scenarios which are actually contraindicated for the CEA. So first of all, if there is a recurrent CCA or ICA stenosis after CEA, these are the ideal candidate for the carotid artery stenosis. If the patient is having a severe cardiac disease or a severe respiratory disease, these are the ideal candidate for the CAS. And if there is a ipsilateral stenosis and the contralateral artery, the contralateral ICA is occluded, these are also the ideal candidate for the carotid artery stenting. And if the patient is having a hostile neck, or if he has received radiosurgery because of the head and neck cancer, so these are also the ideal candidate for the CEAs. And also the surgical inaccessible lesion, like if we find any lesion above the C2, they are not the ideal candidate for the CEA. So these are the contraindication for the CEAs, but not the absolute contraindication. First of all, the advanced age, more than 80 years of age, with the unfavorable anatomy, with the unfavorable access, including the arch disease, sometimes the unfavorable plaque, like the heavily calcified plaque, they are also included in the relative contraindication for the CEAs, and floating clot thrombus. So we have to calculate the risk versus benefit ratio in these patients. So like in this case, this is not an ideal type 3 arch for the advancement of the diagnostic catheter in this for doing the carotid stenting. So we should avoid these arch because this actually required excessive manipulation and increases the risk of periprocessor stroke in these kind of patients. So if the patient is having a arch disease, aortic arch disease, underlying dissection is there, this also increases the periprocessor stroke and mortality. So obviously the heavy calcification, if you ask me, these are the ideal candidates we should send it for the CEA, because there are many issues with the heavy calcification. These may require excessive balloon dilatation. The stent trackability issue is there. The filter trackability issue is there. The retrieval of sometimes the retrieval of the filter becomes very difficult, and there is a potential risk of carotid artery rupture in these cases if we try to overinflate in these patients. And there is also a degree of there is a high chances of restenosis in these patients. So again, the floating clot, there is no absolute contraindication whether to there is no absolute contraindication for the CA or CES or any medical amendment. But in our institute, we follow this protocol. We prime these patients with the anticoagulation, especially the low molecular weight heparin, the Clexin 0.6, the therapeutic dose, and the aspirin, the single antiplatelet, which is to be continued for 7 days. And then after that, we repeat the imaging to see for the resolution of the floating clot. So after we have selected the patients which are ideal for the carotid artery stenting, we always prefer to do a PAC and the cardiac clearance, and antiplatelet loading is very important in these patients. So there are important drugs which needs to be stopped before the CES, especially the oral anticoagulation if the patient is on oral coagulation. So we need to stop this oral anticoagulation and switch to the antiplatelet drugs and before the procedure. And sometimes we may also require to bridge this anticoagulation with the low molecular weight heparin if it is required. And antihypertensive we usually don't stop, but sometimes we usually ask to stop or hold the ACE inhibitor and diuretics, because if it actually continues these drugs, this may sometimes cause the severe hypotension during the balloon inflation in the carotid artery stenting. So these are the basic antiplatelet protocol which we follow in our institute. For the elective procedure, the aspirin 150 milligram and clopidogrel 75 milligram OD 5 days before the procedure, which is to be given in all the patients. But in our institute, it's a referral institute. We always get the patients from distant places, and usually they come here and they ask us to do the procedure on a next day. So we have only 24 to 48 hours to load these patients. So this is how we plan our protocol to prime these patients with the antiplatelet drugs. So if the emergency procedure is to be done on the same day, we load this patient with the aspirin 300 milligram and clopidogrel 600 milligram at least 5 hours prior to the procedure. Or if the patient is planned on the next day and the patient is on a single antiplatelet drug, so then we prime this patient with the aspirin 300 milligram and clopidogrel 300 or 450 milligram, and aspirin 150 and clopidogrel 150 milligram 3 hours before the procedure next day in the morning. And if the patients sometimes are on a dual antiplatelet drugs like 75 aspirin and 75 clopidogrel, and we would like to prime these patients with the aspirin 150 milligram and clopidogrel 150 milligram at the night, and aspirin 150 milligram and clopidogrel 150 milligram 3 hours before the procedure. Yeah.
Okay, so how many of you followed this? It's a workshop, sorry, we need to ask questions. Make sure you're not sleeping in a So this is something which, like, the fellows which join us, they struggle, because every patient who comes for carotid stenting, they have unloaded it. So so some patients will be just on aspirin 75 and they come for carotid stenting. So how do you load them? They are on aspirin 75 for 3 months. So what should be the regimen for those patients? Some patients will be just started, like before shifting, they are now on dual antiplatelets for 3 days. Is it adequate? How do you titrate that? So that's the big question. That's why you see such a busy slide. because there are so many possibilities these patients can have. They cannot be like, most likely they are on single antiplatelet. If they are on dual, it's mostly a recent one. Some patients are on anticoagulant with single antiplatelets because there is no standardization in our treatment for acute carotid stenting procedures. So typically, what this slide wants you to say that before we go in for a carotid stenting procedure, we want that the patient should be well prepped. So if the patient is taking 75 ecosprin for more than 5 days, we consider that part covered. Now we look at the clopidogrel part. If the patient has just been started on last 2 3 4 days, if it's less than 5 days, we consider it inadequate and we give the loading dose of 150 in the night and 150 in the morning. For the neurologist it may seem a bit high, but we are more worried about the stent thrombosis rather than the high dose of antiplatelets here. On the other hand, if the patient is not prepared at all, we are very happy. Then we have a very standard second line of protocol. We give 300 of ecosprin and 450 clopidogrel at night, repeat the dose in the morning, and then go about it. So we have to ensure at least 5 days worth of antiplatelets, either single or dual, have to be in the patient's body before we start. Both aspirin and clopidogrel need to be loaded at least 5 to 6 hours prior to the procedure. We need to give them intravenous GP2B3 inhibitor if we have to do it along with carotid stenting. So platelets, antiplatelets is a very, very important part of a successful carotid stenting. So indication, I think Dr. Anshu has covered. I just wanted to stop you because it's a very busy slide. If you have any questions, it's the time. Please, yeah, please go.
Sir, I recently had one patient, 60% symptomatic calcific stenosis, and he's a smoker, and he had stopped his antiplatelets about a month back. Now he got a stroke in 2000. So now I put him on dual antiplatelets and advised CEA. Is that okay?
So was it a circumferential calcification or just a C-shaped calcification?
Reaction.
So it has to be evaluated on the cross-section imaging on the CT scan, because circumferential calcification becomes it's not an absolute, as I told you, that it's not an absolute contraindication, but it's a relative contraindication. So CEA has much better edge than the CES in cases of circumferential calcification, and especially if the calcification is more than 3 mm. So,
and if the patient is unwilling, then should I continue dual?
Yes, if the patient is unwilling, you have to continue with the dual best medical management therapy.
Unwilling for both surgery and stenting?
Yes. Thanks.
If the patient presents an emergency, so I know I want to take your opinion. So clopidogrel is a prodrug, needs to be converted into some metabolite. Whereas ticagrelor is a direct. What's your take on loading with aspirin and ticagrelor if the patient presents with emergency? In an emergency situation.
See, first of all, we have to look at the imaging part. So the patient is having a TIA or a major stroke. The patient is having a sizable stroke. It's better to avoid the ticagrelor because this increases the chances of hemorrhagic transformation in these patients. So we always, in a stroke patient, we always prefer to load these patients with aspirin and clopidogrel, and especially most of these patients, they are above 70 years of age, and the chances of bleeding in the brain will using ticagrelor and prasugrel rather than clopidogrel is very high, as compared to the clopidogrel is very high. So we always prefer to do.
So if you look at all the cardiology literature, the risk of bleeding with ticagrelor was when there is a previous history of a stroke or TIA. Carotid artery stenting you will be doing because there is a history of stroke or TIA. So that becomes self-contradictory. Having said that, there will be a good subset of patients which we are seeing because our cardiologists have now completely shifted to ticagrelor. So we see a lot of patients who have undergone a coronary artery stenting. They are on dual antiplatelets with aspirin and ticagrelor. So once we know that the patient has a tolerance, we can go ahead with it. But primarily, we are a bit hesitant to start ticagrelor because of the increased risk of hemorrhage in this subset of patients. Otherwise, for rest all the neurointerventions, we also don't use clopidogrel. Carotid artery stenting is the last procedure in neurointervention where we are still using clopidogrel.
But if in cases of emergency procedure, like we are doing a tandem occlusion, we are opening the stroke, like the intracranial vessel and the ICAD and the carotid vessels, we usually do prefer to load these patients with the Belinta, the ticagrelor rather than the clopidogrel, because it will take, after placing the stent, it will take some time to prime this stent for the antiplatelet drugs. So I think in that case scenario, we always prefer to use this.
With the caveat that there should not be a major stroke,
Major
documented stroke on cross-sectional imaging.
Process the patient, for example, after 1 month. What if a situation arises? So, early stroke, always that's a flammable area, bleeding risk is high. So, as per your expertise, what time do you think you practice that after 1 month or after?
There are too many factors in place, because once you open up the artery, there's an increased risk of reperfusion hemorrhage anyway. And if a patient has a previous history of stroke, you are now giving ticagrelor, now you are increasing the flow. So there are too many variables, and old saying of neurosurgery, stroke doesn't kill, bleeding kills. So we are more worried about the bleeding part of it rather than a small clot, which we can always tackle during the procedure.
So as Dr. Gaurav has told that in emergency procedure, we have to use the GP2B and 3A inhibitors as a bridge to the therapy. And then these patients are on, we can we can start this patient on infusion, and over the time we repeat the imaging and do the load these patients with the ecosprin and like the clopidogrel or ticagrelor. So depending upon the infarct volume. So regarding the anesthesia preference, we always try to do all this procedure in the local anesthesia, and MAC may be required in those elderly patients who are not cooperative. And this is the anticoagulation protocol that we routinely use for the carotid artery stenting. The heparin 5,000 international units are given at the start of the procedure. And after that, the most important thing is before deploying the stent and before the angioplasty, we always prefer to load this patient with the 2,000 international units of heparin. So our target is to maintain the ACT level above 2 times the baseline, and preferably more than 300. And after the deployment of the stent, this is a basic protocol. We need to have a control angiogram for at least 30 minutes to look for the clot formation, because 10 to 20% they do have a resistance to the clopidogrel, and they usually have a clot formation on the stent once we deploy the stent in the carotid artery stenosis. So dual antiplatelets, they are to be continued for 6 months, which is usually followed by the aspirin continuation for the rest of the life. But at the 6 months, we prefer to do a check DSA or a check CT angiography to look for the instant stenosis. If it is there, we can continue with the dual antiplatelet drugs. If it is not there, we can continue. We withdraw one antiplatelet and continue with the aspirin in most of the patients. So this is very important question. How do we handle the high BP just before the stenting? And the question is, we don't have to handle, just ignore the BP and we can proceed with the procedure case. But the most important thing is, you have to remember, if the patient is having a BP above 200 systolics, you can take a call, you can stop, you can hold the procedure for a while, and you can prime these patients with the antihypertensive drugs for 1 or 2 days, and then you can take the patient, just a precautionary measure to prevent the higher chances of hyperperfusion injury. So what about the cardiovascular instability, which is actually a most anticipated the complication during the plasty and stenting? So we always prefer to use the most importantly commonly used drugs, the atropine and the glycopyrrolate. Previously we prefer to use atropine SOS. If there is a patient having a bradycardia during the plasty, we give atropine dose. For the last 1.5 years, we have been switched to this glycopyrrolate, which is having a greater safety profile than the atropine. So it's basically a synthetic derivative of atropine, has a greater safety profile and a shorter half-life, and thus less side effects. So we prime, but this glycopyrrolate we usually give prophylactic to the patient just 5 or 10 minutes before the plasty. So this is a representative case demonstration where after priming the patient with the glycopyrrolate, we hardly found any change in the pulse or significant change in the pulse and the BP. So how do we manage the hypertension after the CES? Usually we prefer to use the levodopa, and the alternative is the clonidine. We can also use the anti-G, but increases the chances of cerebral hyperperfusion injury. Our target is to maintain the mean BP around 70 to 80 in most of the patients, strictly around 70 to 80 in most of the patients. So this is a classical example of a cerebral hyperperfusion injury. We did a stenting in one of the elderly patients, 82-year-old patient, and he had a bleed after 16 hours after the procedure because of the uncontrolled hypertension. So this can be a very catastrophic. So these are the possible risk factors: the ipsilateral stenosis and ipsilateral absent ACA, the impaired collateral supply, and especially the perioperative and postoperative hypertension if it is there, which has to be corrected, which can be corrected with the antihypertensive drugs.
So just a one word I want to add here. So all these patients, they don't need to have a sustained high blood pressure to get these deperfusion bleeding. Even just the high blood pressure for 5 to 10 minutes is enough. So we have to be really on top of the things, and we are fortunate we have a dedicated neuroanesthesia and critical care team who has been now there for more than a decade, so they know. But the moment a new person walks in, we have to tell him it's not okay for this pressure to be high for 5-10 minutes. It's not okay. So they always will come up with that. I have given the drug, it will take its time, be patient, 10-15 minutes it will come down. That's not okay. So we said, like, it has to happen now. So we start talking to them the moment the stent is done, before we are doing the plasty. If it doesn't drop down on its own, we really push them to bring it down with labetalol or anti-G infusion.
So if the clot formation occurs, we have some rescue drugs to deal with this clot formation in the stent. So after the deployment of stent, as we have discussed, that we do a control angiography for at least 25 to 30 minutes to look for the clot formation around the stent. And again, our target ACT is usually maintained above 2 times the baseline and preferably above the 300. But despite our all effort, if we find clot formation, we usually prefer to give the bolus of epsiximab 0.25 milligram per kg dose through a guiding sheath directly intraarterially, which is to be followed by the 12-hour IV infusion, which is given in a dose of 1.125 mcg per kg per minute. So after that, we usually watch for any neurological deficit. If it is there, then we can take again to the lab and we can give these epsiximab again. So this is a case example. After deployment of the stent, there was no clot formation when we watched this patient and maintained ACT above the 2 times the baseline or above the 300 levels. So despite our best effort, the patient had got clot formation around the stent. So we watched for another 15 minutes. So it was not resolving, it was progressing. So we then gave a bolus of epsiximab. We waited for a while. So epsiximab was, the patient was primed with the epsiximab 10 milligram. After that, we found that there was a stabilization, there was no progression of the clot, and there was a smoothing of the clot along the stent walls. So this is how we tackle the clot during the stent placement. So this is also an important practice which is being done routinely by the cardiology people. They use the temporary pacing. So we don't really use temporary pacing in most of the carotid stenting patients, but we do recommend in cases of the critical aortic stenosis and those patients with a very low LV dysfunction, very low LV functions. So coming on to the timing of the CES, when should we do CES? This is a very important question and confusing question among all the physician and the interventionists. When should we do carotid artery stenting? The most important period. It should be done as early as 2 weeks to get a maximum benefit. So, but it is supported by the imaging also. So we have to make a decision based on the imaging. If these are the case example. If the patient is having a very small infarct, these kind of the patient can be treated early within the 2 weeks. So decision is to be taken only to prevent the reperfusion injury, because the sizable, if you are treating, if you are aggressively treating the carotid artery stenosis in a patient with a sizable infarct, the patient can have a rebleed or a hyperperfusion injuries. So like in these cases of small sizable infarcts, we can we prefer to do after 2 weeks to prevent the hyperperfusion injury. Like in these kind of large sizable infarct, we prefer to do after 4 weeks. And especially in the perforated area infarct, like the large basal ganglia infarct, they do have a very high tendency of free perfusion injury after the carotid artery stenting. So we prefer to do this, delay the stenting for at least 4 weeks in these patients. And if there is already a hemorrhagic transformation set in, so we always try to delay the procedure for at least 6 to 8 weeks to get a maximum benefit. So coming on to the hardware and equipment which we are using for the carotid artery stenting, first of all, starting from the base camp, by default we are using a 8 French or 9 French sheath in almost all kind of the carotid artery stenting. 9 French is commonly used when we have to use this, some form of EPD device like the Gore flow device. They actually can accommodate only 9 French sheath. So accommodated in the 9 French sheath. And these are the basic diagnostic catheter, like the Picard catheter, which is 100 centimeter diagnostic catheter, which is used to take an angiogram just before the planning the carotid artery stenting. And we can also alternatively use the H1 catheter, which is also very commonly used. In case of bovine arch or type 3 aortic arch or unfolded aorta, we can also use a reverse shape catheter like the SIM2 catheters to cannulate these arteries. So guide wire, preferably 035 wire, Thermo wire, or 038 wire can be used. J-shape, these are J-shape wires. So sometimes in case of very tortuous anatomy, in case of unfolded aorta, type 3 arch, we sometimes may require a more stiffer wire, which is an implants wire. It's not an hydrophilic wire, which actually ease the trackability of the stiffer guiding sheath into the CC. So this is a basic assembly. This is a coaxial assembly which we, after placing a 8F French sheath, we use this coaxial assembly, the Neuron Max and the Picard catheter, so or any guiding sheath or any arterial sheath which is around 6 French. But to place an EPD or to place a stent, we need to have a guiding sheath of with an inner diameter of at least 0.87, more than 0.87. So coming on to the micro wire, if we are not using like the EPD device or EPD devices like the filter wire, so we can use this wire. The Traxxas wire is very commonly used, the transient wire, and we can also use the cardiac wire, which have very high torqueability. They are very commonly used for the carotid artery stenting. They are stiffer wire, and the trackability is excellent. So coming on to the embolic protection devices, we have a filter devices, we have occlusion balloon devices, we have a circulatory control devices, and the most commonly used devices are the Spider X and Ambo Shield. In our center, we are using an Ambo Shield in most of the cases. We have a different category like the distal embolic protection device and the proximal embolic protection device. So coming on to the angioplasty balloon catheters, these are used to pre-dilate the lesion and post-dilate the stent if there is a residual stenosis. So there are certain points while using an angioplasty, while doing an angioplasty, which has to be kept in mind. One is we have to undersize to the diameter of the non-disease ICA. We cannot oversize the balloon because it can rupture the plug, it can rupture the vessel also. So, so this is very important. And secondly, the balloon longer than the lesion is used, especially most of the cases, the 20 to 30 mm balloon will do the work. And sometimes in cases of longer lesion, we sometimes may have to switch to the 40 mm balloon length size. And the most important thing is, while doing an angioplasty, you should always keep the guiding catheter hub open so that any embolic material or clot may come out of that this hub. And single inflation is strictly recommended. You don't have to do a repeated inflation because it can increase the cardiovascular instability risk and complications. And post-dilatation is always recommended only if there is a residual stenosis or if there is a waste left after placing a stent. You don't need to perfectly match, perfectly or parallel the stent. So coming on to the stent, we have different categories of the stent: non-tapered, tapered, and open cell and closed cell design stent. So there is no pure randomized data which has suggested the superiority of the one kind of stent over the other stent. There are some small studies, but they also found that there is no superiority of one stent over the others. So in our center, we are frequently using the exact stent, that is a closed cell stent, and the CGuard stent, which is an open cell stent. So in literature, it has been written that the closed cell stents, they are preferable in the straight vessel with ulceration and calcification, and the closed cell stents include the exact and the wall stent. And the wall stent has, in an unconstrained position, it has a very good flexibility, and we can also place in a tortuous anatomy. And the open cell stent and the hybrid stent, they are preferred in the tortuous anatomy, like precise and protege and neculing, and also the CGuard stent. So this is a small study which found no difference between the two groups in the open cell and the closed cell stent. So so it's the operator choice and operator demand, like they can do with either of the device. So in case, but what we prefer, if there is an ulceration, if there is an ulceration underlying the carotid stenosis, we always prefer to use a closed cell stent. So this is again a smallest meta-analysis of the which has compared the two stents, different kinds of stents, geometry, and they found no difference in the cardiovascular complication or stroke with either of the stents. So nowadays we are coming up with the mesh stents, which include the CGuard, the Gore carotid stent, and the Road Saver stent. I think the CGuard is available in our country, and we are frequently using it if we don't have to use a filter. So this is a CGuard study, and they have shown a good effectiveness in the carotid artery stenting patients. And this is again a study which has shown the comparison between the two stent. So there is no difference between the two stent in case of safety and efficacy. It's an operator choice. But if you ask me, and we are frequently using an exact stent, probably because the ease of deployment is excellent. So exact stent can be easily deployed just by clockwise rotating the hub, and you can precisely deploy the stent. And in case of like CGuard, you have to do exchange maneuver, and it can sometimes can cause the non-precision deployment of the stent. So what about the access? We prefer to use a femoral access, but in some of the centers they have switched to a radial access, and in cases where there is a severe atherosclerotic disease involving the femoral or radial or like other side, we can also switch over to the brachial route or a direct carotid route. The transfemoral route is an most commonly used route. So how do we do this approach to this lesion? So this is an ECA first technique. What we do is we place an 8 French short sheet in the groin, and we use 8 French guiding sheet, which is actually advanced over the 5 French catheter. How it is advanced safely? We first choose ECA, healthy ECA. We advance our wire 035 or 038 into the ECA, and over which we advance our 5 French guiding catheter, and with the help of the coaxial technique, we advance the 8 French guiding sheath. So this is the safest and the ideal technique to track our guiding sheaths. So this is sometimes if the guiding sheath is not tracking because of the tortuosity, we can use a stiffer wire, 038 wire, in case of instead of 035 wire. So like in this case, we use an 038 wire. So sometimes we also may have to use a SIM2 or exchange or implant shift wire assembly. Like in this case, there is a reverse anatomy, there is a type 3 arch. So this is a SIM2 catheter. You can see that the Picard catheter initially was used, but we were not able to cannulate this artery. So then we switched to a SIM2 catheter to easily access the artery. Then we use this implants wire, exchange implants wire, and to track this guiding sheath into this ECA. So it's not always a success in all the procedures. Sometimes in patients we had encountered some difficulty in trackability, and we had failure in 1 or 2 cases because of the excessive tortuosity of the aorta and the unfolding of the aorta. Like in this case, we tried different maneuvers, different techniques, and different guiding sheath and catheters, but we failed to track our guiding sheath. So it's very important. You should leave your ego at the door of your cath lab. Your goal is not to do 100% of the cases. The patient safety is very important. You can you can shift this patient for the CEA if they are eligible. So sometimes the routine access is blocked, or there's a critical stenosis. We can switch to radial or brachial route, or we can also use the transcervical route. Like nowadays, the TKR, that is the transcarotid revascularization, is a much safer procedure than the CE has been done. They have been tried. They have done a few number of cases with a good safety. The small incision is required, and they do a flow reversal, which is connected to the some system, so to prevent the embolic phenomena during the procedure. So for the radial, we have done few cases with the radial also. These are the set of the hardware which we are using for the radial: 5 French sheaths into catheter, blast. Blast has a good trackability for the radial route, and we also we have to use the exchange wire, and especially the implants wire, to place a guiding sheath while you are using a radial route. So the most critical step in doing the radial access, using a radial access, is the guiding sheath placement through the arteriotomy site. That is very important. And secondly, we have to dilate the vessel. Most hurdle comes when there is a spasm at the radial side, because we are using 6 French 8 French sheath in this part, and this may sometimes cause a severe vasospasm, and we sometimes fail to negotiate a small catheter beyond this smaller vessels. So, and we have to prime the vessel with the heparin also. So we dilate. Our protocol is to dilate the vessels with the 1 ml dilation and 100 mcg NTG, and sometimes imodipine is also required. We always sometimes prefer to prime the patients with the imodipine. So this is how we do a radial technique. The radial this roadmap is taken, and the SIM2 is advanced to the CCA, and after that, with the help of the O38 wire, the SIM2 is advanced into the ECA. We can also either use the implants, and we can exchange with the guiding sheath over the exchange implants wire. So there are different case scenarios sometimes we encounter in our practice. Like in cases of bilateral disease, we have to stage this patient rather than to do a simultaneous approach to in these patients. Like in these, if the patient is having a bilateral stenosis, so what should we do? We have to treat the symptomatic side first. If the patient is having a right ischial stenosis and left ischial stenosis, we have to treat the symptomatic first. So in case of asymptomatic patients, what should we do? We have to treat the critical most side first. So in this case, this is a 90% stenosis, this is a 60-70% stenosis, although there is ulceration, but we will always like to prefer to place a stent in left side first rather than to right side. And in case of asymptomatic bilateral critical stenosis, we have to treat the dominant hemisphere artery first, because the dominant territory infarct can be catastrophic. So what are the treatment strategies if we have to follow if it is the carotid artery stenosis is associated with the triple vessel disease? So in cases of asymptomatic stenosis with the triple artery disease, in these patients, so we always prefer to send these patients for the CABG and CAA. The safety is very good in the, they have been tried and tested in most of the centers, that the concomitant CE and CABG is safe and effective procedure. So in case of isolated single vessel critical stenosis, or there is a contraindication for the CA, we prefer to do a CAS first, and we prefer to do a CABG at least 1 month later after the CAS. So coming on to the vessel closure, the manual compression is the most commonly used in most of the centers. It's a gold standard for achieving a stenosis, but it's quite laborious, time consuming, immobilization of the limb is required, and it is quite difficult in obese patients. So we have different types of closure devices, angioseal and the perclose device. The most commonly used is the perclose device, which is a suture-based device. And for the radial artery, we are using a TR band, which is a transparent band. It's an excellent band. We can we can do a controlled, we can achieve a controlled hemostasis with this band. So Dr. Piyush will also be discussing about the closure device at the end of the talk. So I'll request Dr. Gaurav to talk on the complex carotid stenting.
Okay, so any questions? No? Okay, so one word of advice, when you start doing carotid stentings, and I know most of you are in the early phase of your stenting, do not attempt it till you have done at least 50 diagnostic angiograms. So you have to build up your practice system, learn the access, learn different hardwares, wire, catheters before you attempt the simplest of the carotid stenting. I'm going to show you some of the complex cases where we have got stuck or we had to use different bailout strategies. It's not to scare you, it's just to show you the spectrum which can be done. But by and large, the whole purpose of doing this workshop was to make you aware that, you know, when you do a carotid stenting, it's not just simply going in, putting a stent and coming out. So there's a lot of thought process, a lot of protocolization which has to be there, and I think Dr. Anshu has covered most of it. If you have any questions about it, feel free to ask now, later at the dinner, or you can take our numbers and call or email or WhatsApp, whatever you want. Okay, so we do complex case scenarios, and that can be related to decision making, and I think this has been, we are talking about it since evening. Dr. Simar was talking about it, that there's a stenosis and then there's a intraluminal clot. So patient had a small stroke, patient had a tight stenosis, and also there is a floating clot. Now what should we do? Should we stent these patients? Should we send these patients for carotid endarterectomy? Should we start on antiplatelets? Should we start on anticoagulants? Should we start on both antiplatelets and anticoagulants, or do nothing? Single antiplatelet and anticoagulant for how long? For a week. Okay, and then do what? Sorry, can you just take a mic and then try intervention? Okay. Anybody differs from him? Has a different thought? What will you do if you see such a patient? What will you advise? Okay, why not just send him for endarterectomy right away? You are shaking your head, but why not? It's not always possible. That's the question. So number one, like in this case, the clot may be extending too distal, so you may not have a distal control, and while you are trying to manipulate, the clot may actually migrate forward. So that's the most common thing. So these are the options which you consider, and we follow what you just said, that we put these patients on single antiplatelets and anticoagulants, wait for a week, repeat the angiogram after 7 to 10 days. Our typical thing is 7 to 8 days. More than that, the patient also gets jittery in the hospital. Most of the time the clot is gone, it's a smooth looking plaque, and then you can just go ahead and stent with the usual precautions which you take. So another case came with an acute stroke. We started the patient with IV thrombolysis, and we decided to wait, starting on the antiplatelets, and the clot is gone now, and we can go ahead. Sometimes the decision is not so simple. So sometimes what is happening, these patients are having a crescendo TIAs, and at that time you may have to do an emergency stenting or send these patients for endarterectomy. So this was a patient who came to the emergency. Came with a TIA, started on dual antiplatelets, still had symptoms, started on Clexane, again had symptoms, and we could see a floating clot sitting there. And in view of crescendo TIAs and by the time we are just loading these patients, the options of endarterectomy is wearing away, because then you need to wait for some time before you can take these patients. So what we did is, we decided that the clot, we looked at the image, and if you can see here, the clot is just on the one wall as the green arrow is trying to point there, and we can point our wire away from the clot, place a filter up, and do the stent. So it's not an absolute contraindication if the clot is just on the one wall, but if it's a free floating clot in the lumen, then of course you cannot do it. Another case, recurrent TIAs, free floating clot, but patient is having repeated symptoms. Vessels upstairs looks okay, so we send these patients for endarterectomy. So I'm just trying to show you different spectrum where you end up taking a different decision in sort of similar looking clinical scenario. So this is the complexity as far as decision making is considered in TIS. Now, what will start happening is, as you start doing more and more, it's a natural tendency for a center to gravitate towards one side. So since we do a lot of stenting, our neurology team will start referring more and more patients to us. We end up doing more stentings than endarterectomy. So, and as you start doing more, you start intervening more complex cases too, and there are borderline cases which you start pushing them on. So complexity can be increased because there could be tortuosity. Now you need to take your wires up. If it's a straight pipe, it's easy to take. If there's a 360 turn, you will get stuck. So you may have a situation where when you try to pass the wire, the whole intima is folded. This can lead to more clot formation. So when you see this, you need to increase the heparin level during the procedure. When we always talk about placing a filter, now if we have to take a filter across this curve, it's working? No, it's not working there. Do we have a pointer? So if we have to take the filter across, it may be difficult because of the tortuosity of the artery. So we can look at it that we have a safe margin from the stenosis to this turn, and we can place the filter before taking this bend. So we have a distal protection device. So distal protection just means it is to be distal to the stenosis. It doesn't mean it has to be distal into the brain. So plan that thing judiciously. So another patient, like same thing I think. So we just place the filter here, do the stenting under protection, and we are done. Another case, a bad looking loop. So these cases are not contraindication for CAS anymore, because you can place the filter proximally as long as you have a good safe 3 to 5 centimeter margin distal to the stenosis. Sometimes these loops get straightened as you pass on the wire. These loops can get straightened, and okay, I think that should be a video. No, it's running. Yeah, so you can see the loop is here, but it has got straightened as we have passed the wire, and then it's easy to place the filter up. Now we know of many centers in our country which do not use distal protection devices, and whatever data, and it's particularly the All India Institute which does almost all carotid stentings without filter. So, and the data on filters is still shaky, and we like to use filter in almost every case, but sometimes if we feel that we do not have a good safety margin, and if the plaque is not ulcerated, it's not a hot plaque to say, we can also consider doing it without filter protection, because it's easy to pass neuro wires up across all the tortuosities. It's just that the filter wire is stiffer, filter itself is stiffer, that may get stuck into these tortuosities. So if we do not have a good landing zone of 3 to 5 centimeter, we think the plaque is stable, it's not a ruptured ulcerative plaque, we can consider doing them without filter placement also. Or these days, as Dr. Anshu was saying, there are mesh stents which have a mesh over the stent. So what typically happens is, Most of the embolism during carotid stenting happens when we are doing a post stenting angioplasty, because the stent is here, then you inflate the balloon, you are crushing the stent into the plaque, and that's the time the plaque will protrude through the stent and can cause distal embolism. Now, if there's a mesh which is covering the stent, then that protrusion of cholesterol plaques or whatever we want to say into the stent stud doesn't happen. So that's the concept of these mesh stents, that you don't need to place a filter. It's because they have sort of to say inbuilt filter in them. So we can also use devices like C-guard if we cannot place a distal protection device. We have one case of MoMA filter, which is a proximal filter. I've done it once. It's too cumbersome for me, and I've stopped using it. But if you are competent enough, it's like without crossing the stenosis, you place one balloon in the ECA, one balloon in the CCA, you reverse the flow. So any debris which may fly off into the internal will just come back into your suction pump. But it uses a bigger systems, and generally nobody uses them anymore. What about ulcerative plaques? As I said, we should always use filter in this. Sometimes we use dual protection. So we will use a filter also, and we will also use a mesh based stent, so that I have protection throughout. I have protection during the pre-plasty, and I have more protection during my post-stenting plasty. Severely calcified plaque is an is a gray zone. So most of them we can see if they are circumferential, if they have a thickness on CT scan, then we can send them for endarterectomy. Also, if you are stubborn, you can try doing a stenting and angioplasty, but it's not a pleasant experience, primarily because it's difficult to open. They need a lot of balloon manipulation. So here you can see we are using a 315 balloon first to open and create a channel, didn't work. We are using a 420, didn't work. Then we have to use bigger balloons before we could finally open up a channel into this to place the stent. So that's a big balloon plasty which we have to do to make the stent fit into that place. So eventual result is good, but our usual time will be 20 to 25 minutes for a carotid stenting. In this case, it's almost a double. So if it's a severely calcified circumferential plaque, probably we are better off sending them for stenting. But if it's not a circumferential plaque, if the thickness is not much, you can do plasty and place stents in these. Now that's my favorite thing, a multi-channel occlusion with distal collapse. So this patient had a history of infarct. CT angiography practically shows that there is no ICA. It seems like a complete occlusion there. You look at this picture. So this is the external carotid, this is the internal carotid, seems to occlude, and then there is like a rete of channels which is reforming the ICA, which seems to get occluded because there is a slow flow all the way into the MCA. Now this is a challenging case to do, primarily because there is no main channel left. So what we need to do is look at this picture here. So this is the angiographic run. There's rete of channels which is reconstituting the ICA, and these are difficult cases to treat either ways. So what we need to do is forget about the filter for the moment. We take a wire with a microcatheter, try to dig through these channels, and this is the contrast stasis, because these are so small channels that just with the microwire we have a stasis of contrast. We exchange it to a filter device, place the filter, and then proceed as we will routinely do. So we have to use a microcatheter wire exchange techniques to do these difficult cases, and that was the final outcome. So we have multiple patients like this now with very bad looking ICA, rete type of collaterals. The wire will be difficult to cross in. We have to use support of microcatheter to dig a channel. It's basically you are digging through the internal carotid artery to find a true lumen and open these arteries. So these are again like bad examples. If you look at the CT angiography report of most of these patients, it's gonna say complete occlusion of the ICA. but it's not a complete occlusion. There is a trickle of flow which is there, and that is probably causing a lot of emboli to the patients. And these are the subset of patients who won't benefit for endarterectomy. These are the patients which definitely require a stenting to open up a non-existent channel. And this video should probably give you an idea that how challenging it is. So it takes a while uh, to get used to finding the true lumen, because your wire will get stuck at multiple places, and just by the feel of your hand you know that you have crossed into it, and then you start dilating and putting stents into them. Then this is a balloon occlusion with distal collapse, similar looking picture, crossed with wire, and we did it just with that, no filters involved. So I'm just going to skip this in interest of time, but it's the same sort of, so just to show that there are lots and lots of these patients who have these rete like channels with collapse. And Dr. Anshu has written this paper describing initial first of our cases, and now we have a long series of these multiple cases. Coming to another complexity of tandem occlusions, I think this gets covered in stroke, that if you have a carotid stenosis and a middle cerebral artery occlusion, what should we treat first, the stenosis or the cerebral artery differently, antegrade versus retrograde approach? Typical answer is do a plasty first, make your way, go up, open the artery, then come back and put a stent. Think about alternate routes like radial for complex challenging arches, as Dr. Anshu was trying to show you. And so when we say radial, somehow it comes across that it's the simple thing why we were not doing it for so many days and years. So the problem is not everybody will have an easy access through radial too. When you start doing radial, you will realize especially the right common carotid will have a sharp angulation, and it may be difficult to track your catheter up. Like in this case, we really struggled to take our guiding up. We inflated a balloon to actually pull it up, but that also didn't work. So after trying for like good 40-45 minutes from the radial side to take our guiding up, we switched to femoral root, which was our regular thing, and in 5 minutes we were up. So don't be stuck up that okay, I have to show that I can do it from radial and I'm stuck on it. Some patients' anatomy may be easier to do by femoral root than by radial root. So okay, so these are few of the examples where if the arch is not so bad, radial is good for the patient, because you can put just a TR band, and he is mobile, he can move his leg easily, and all the usual advantages of radial. I'm just skipping in interest of time so we can get more time for other things. Okay, so these are all radial examples, making loops and coming up. We can skip that. Okay, this is one failure which I want to show. So 85-year-old gentleman, TIAs, there's a calcified plaque, posterolateral calcification with a very right angle origin of the internal carotid artery from the common carotid artery. So if you just look at it prima facie, it looks super simple to do. You know, the artery is smooth, there's a good distal landing zone, no tortuosities, but this is the sharp turn at 90 degrees. So we did our plasty, we tried tracking a balloon. Then comes the problem. Whatever stent we wanted to do, it won't track because it's a sharp angle, and everything will start projecting into the external carotid artery. So we tried with open cell, we tried with closed cell, we tried with mesh. It didn't work. So we are back to square one. We have done a plasty, we have crossed with the wire, but the stent is not going through because it's a bad angle. So we tried a lot of things. So we tried taking a guiding catheter across, but that also didn't work. We tried inflating the balloon distally to pull these guiding catheters up. That also didn't work. And we tried with our neuro distal access catheters, which are super soft to track. that also won't track. So eventually, after a lot and lot of attempts where we have tried almost every possible combination of hardware, straightened the artery completely, it won't track. So that's a failure for us. So, and eventually we were reflecting that it's only the balloon which was able to cross. Rest all these stents were finding it difficult. So what we did is we took a cardiac stent which is balloon mounted. Not the idealist situation, but that was the stent which could track easily because the balloons were going. So we used a coronary balloon mounted stent there to open up the artery, and that sort of did the trick because the patient didn't need 100% lumen. We could open it to good 70%, leaving 30% residual stenosis, but that was good enough for these patients to have a good circulation and perfusion. So sometimes just thinking out of the box using a different technology also may help you. Okay, another patient, 41-year-old, TIAs, CT angiography shows dissection, patchy right MCA territory infarcts. She was referred to our hospital. This is the picture. So I think we were having the discussion in that hall about such patients. So this is the repeated TIAs despite being on medical management. You can see the artery is dissected here, getting closed. That these are the lines. So that's the selective run, and since the vessel is so narrowed there, it's almost about to close and there is no good collateral circulation, we decided to intervene. The patient is also harboring an aneurysm, which we realized as we went in. So as we're going to increase the flow, are we increasing the probability of this aneurysm to rupture? Nobody knows the right answer. Lady was having this ICA flowing few days back, and the aneurysm was there for a long time. So we decided that if we keep her normotensive, the risk probably should be the same. We did offer a treatment for aneurysm also in interval, but she refused for that. So using standard techniques, we cross it, and at these places, at the near the curve, you won't be able to track the carotid stent. So we again used balloon mounted coronary stents to open up the lumen. So this is the deployment of balloon mounted stents, but one was not enough. It's a long standing dissection, and at this point now, since we are in the cervical segment, we telescoped it with a regular carotid stent to gain the length. So that's the telescoped segment, and now the whole artery is completely open. And as I said, the aneurysm is filling. We wanted to tackle it. It's more than a year now. She still refuses treatment for that aneurysm. Okay, do we have time? Yes. Another. So similar looking another case who presented with acute stroke, 55-year-old male, high NHS of 20, code brain was activated, perfusion showed gross mismatch from CBV. It looks like the ICA is completely occluded. When we did the CT angiogram though, we found the MCS flowing, the ICS seems to be flowing, there is no occlusion whatsoever. So what's happening here? Patient got TPA, there was a dissociation. We took this patient and found that the patient is having occlusion of the ICA, probably due to dissection, and we were not able to see it because probably the dissection started at the bony canal, and the CT angiography we didn't see it properly and we missed the dissection at the bony canal. So now since we know, now it's simple, like you cross it and you start placing stents. So this is with the wire. We tried crossing the carotid stent, didn't work. So we took intracranial stents which can track easily. So first stent, second stent, third stent. Finally, after the fourth stent, we could restore the flow. But as we were waiting, I don't know if you can appreciate, there are a lot of these white plugs which are clots which have formed in this stent because there is a lot of metal in acute emergency situation. We have to give GP2B inhibitor, and this is the CT at 48 hours and day 5. post procedure. Patient recovered completely. So to conclude, I just want to go what we have discussed so far, and then we can take questions. So, what degree of stenosis I should stent? Asymptomatic more than 80%, symptomatic more than 50%. Catch is this cannot be on Doppler. This has to be either a CT angiogram or DSA. MRI and Doppler may be unreliable here. Two, when should we do a stenting after stroke or TIAs? Minor stroke, TIAs, or stroke with small TWI lesions around 7 days. If it's a moderate to large infarct, it's prudent to wait for 3 weeks and return of some functionality before we plan stents. Antiplatelets, I think we have discussed enough that we need good loading dose worth of 5 days of antiplatelets before we can put these stents. Which route should I choose, radial or femoral? Depending on the anatomy, if you're stick with femoral. Though if it's a bovine origin or a bad type 3 arch, you are better off with radial. Rest all, I think femoral does a decent job. Don't be dogmatic about one route. If it's not working out for you, if you're struggling, you can easily switch to the other route and see if you can save time and do the procedure. Should I use a filter or not? Our philosophy is if there is no contraindication, why not? We should use it. If crossing the filter is a challenge, if by putting the filter we are taking an additional risk of dissecting the artery, increasing the procedure time, then probably we can use mesh based stents and avoid a filter. Which stent should I use? Most of the trials recent times have been done with closed cell stents, so we stick with closed cell stent. As we said, if we are not using a filter, then we can consider a mesh stent. If it's too tortuous an anatomy and you are worried about straightening, then probably you can use an open cell stent, though we generally don't use it. How to size the stent? Size it to the proximal diameter, not to the distal diameter. Use of tapered stents take care of the discrepancy between both internal and common carotid artery. And if you are in doubt, always oversize. Don't undersize the stent. And how to size the balloons? Typically, we do pre-plasty with a 3 millimeter and post-plasty with a 4 or 5 millimeter balloon. But again, depending on the patient's anatomy and diameter, you can change that. The last thing, sometimes when you're trying to withdraw the filter can get stuck into the stent. So at that time, you can do simple maneuvers like moving the patient's neck so the filter can move away from the stent. We can use the guiding catheter to advance. We can also use balloons to pull out the filter devices. And how to tackle the stent clots? We always wait good 15 to 20 minutes after deployment of the stent to see if there is any clot formation. Do not just deploy the stent and come out immediately, because then you will miss the acute clot formation which is happening in the stent. If there are clots, you give medications to resolve them. If there are resistant clot, consider putting these patients on IV infusion for few hours. And we can also do an aspiration through guiding catheter to manually suck out the clots. Post procedure, what to handle? Blood pressure, that's the cardinal thing. Keep the mean blood pressure around 70 for next 12 hours. The usual questions will be, oh, we started with a systolic of 200, now you are asking for a mean blood pressure of 70. It's okay. Low blood pressures are fine, higher is not okay. Use closure devices, it helps. Patient's compliance is better. You will get a better control of blood pressure because the patient is comfortable and not in pain. Always use Foley's catheters in elderly, and do not start antihypertensives till blood pressure starts to rise, because you are stretching the baroreceptors and the blood pressure may remain on the lower side for some time. We do follow up at 6 months, either mostly with CT angiography, rarely with DSA, and after that we can continue screening them with Doppler or CTA if required. Typically in our setup, dual antiplatelets for a year and aspirin for life. So that's all from my side. Where's Piyush? Piyush is here, and he's gonna show you a short video of how to use closure devices, and then we can end the symposium. It's here? Okay, perfect. Any questions while we are setting this up? Or it was too much? Yeah.
Good evening, sir. I'm Dr. Rakesh, neurosurgeon assistant. We had a patient of 70-year-old sir with symptomatic around 60% stenosis left ICA. So he was on single antibiotic for about 2 weeks and pre-procedure we covered with 300 eposprin and 300 clopidogrel. And the Intra procedure was uneventful. But after about 6 hours, patient developed slurring of speech and right-sided weakness. So again, DSA has been performed and there was complete stenting. What would be the reason for stenting and how to proceed?
Okay.
He had developed good collatus, so he was we managed conservatively.
So first of all, your clopidogrel dose was too low. So you loaded only with 300. So if the ideal dose is 600, so typically we divide like 450 at night and 150 next day morning. Or if you have to do it in one go, 600 at least. So your clopidogrel dose was way too low. That's probably the number one reason. Number two, I don't know if you waited for 15-20 minutes after the stent deployment to see if there is an acute clot formation. Sometimes you will start seeing the sometimes you will start seeing the clot formation in next 15-20 minutes itself, and if you do not tackle it there and then, by the time the stent gets occluded or through an emboli, it's just too late because the patient already got a stroke. So I've seen many people, because the lab time is limited. You are sharing the lab with other colleagues, cardiology people are on your head, somebody is waiting, there's an emergency coming. So typically you will do the stenting, maybe do another run in 5 minutes, everything looks fine, and you say, okay, pack up, let's go home. But waiting is equally important, because if you see the clot building there and then, and we do see like almost 20% of our patients, we do see minor clot formation, and we have to give Riopro almost every 20% of the patients. So if we do not do that, then we will have a higher incidence of embolism, stroke, and instant thrombus. So he's on phone. So I wanted his opinion. So I do not recall a peri-procedural stroke in last 10 years. So we have 2 or 3 patients of delayed reperfusion hemorrhage. We have lot of patients of clot formation, minor clot formation during the stenting. But to have a full-fledged stroke during a procedure, I have not yet seen it. How we can tackle, though, I have an answer for you, because the way we tackle when we do tandem occlusions, that's the time there's an MC occluded and there's a stenosis and we do the plasties and go up. So if you see a major vessel getting occluded, you have to proceed like a stroke. Use your stent retrievers or aspiration catheters to try to take it out. If it's a minor vessel, again just use Integralin or Riopro to lyse it. That's the only solution you have.
He is a chronic smoker, but no other comorbids, no diabetes, no hypertension. And generally, we have protocol. If there is complete occlusion, we should not do anything. I just want to clear it out because he is only 45 years. So he presented with right hemiparesis and motor dysphasia. And hemiparesis improved with time, and there was infarct in left precentral gyrus region, and there was complete occlusion of extracranial left ICA and intracranial MCA. But there was reperfusion, like collaterals were formed in the branches of left MCA. So because initially I gave for 1 week like anticoagulants and single antiplatelet, but there was complete occlusion, and after 1 or 2 weeks there was no improvement, so I just put him on double antiplatelets. I just because he is improving, like he is speaking now, but not fully improved. We should intervene something, or double antiplatelet is enough?
So if there is a complete occlusion, I don't think we can intervene. Like, and I'm assuming you have done a CT angiography or something to demonstrate. So if it's a CTO, we should not intervene until unless the patients are presenting within the window period and there's a big perfusion mismatch which you're seeing. The way you are describing it, it's a long-standing CTO, so I do not see any merit in intervening at that point.
Patients like big infarcts with significant midline shift of flight and undergoing emergency decompression. As it is an emergency procedure, decompressive connectomy, so we cannot do everything that time. So after the procedure, after decompression, if patient improves, so life, if the patient still lives with any side of hemiparesis or with aphasia, can we go for the intervention after doing DSA and NGO?
How much after are you talking about?
Maybe if patient improves after a week or after 2 weeks. I'm not talking about the patient who will be on tracheostomies, improving very late.
So typically, if the patient is having such a large infarct with a midline shift requiring a decompressive, I don't think they're going to improve in a jiffy in a week, 10 days time. So they will take their own time, typically more than a month or so, if not more. And my advice in that situation will be again that let the patient have functional recovery, because they may be dependent. They will need a lot of, sometimes there's a Foley's inserted, they need lines and all those things, and you don't want to start antiplatelets in a situation where you just cannot stop.
Yeah.
So if it's done, if it's a craniotomy or craniectomy, if it's a craniectomy, you need to replace the bone before you do the stent. So typically there will be a good gap of 6 to 8 weeks before you even consider putting a stent.
Because doing cranioplasty is minimum after 3 months, not immediately, minimum after 3 months. And suppose patient which has undergone decompression and improves not immediately after a few days, 5-7 days, and gain consciousness. GCS is about E4, V1, M5 or sometimes M6. Can we go for the
So I'm assuming there's a large infarct, so my typical waiting period will be minimum a month before I will decide to intervene, because otherwise there's a high risk of reperfusion happening. So I will look into that factor. I will look into the factor that this patient will need a cranioplasty later on, and he has to have some functionality regained before we can even consider having a preventive stenting done for him.
So after 1 month only we can think about
With a major infarct, yes, minimum period is 1 month.
Thank you, sir.
Do you suggest, as madam had discussed one case, critical stenosis or complete occlusion, do you suggest that CT angiography is sufficient enough, or should we give in certain cases benefit for angiogram DSA?
So as I was trying to show, like all
Yes.
those patients on CT angio, they were reported as complete occlusions, but they are all reconstructed images. If you have a good CT angiography and a good radiologist who can interpret, fine. But if you have a doubt, it's better to do a DSA. Sometimes you do get surprised. You see some of those channels which you do not appreciate on CT angio. Ready? Okay, so we go to groin.
Thank you so much, sir. Good evening, everyone. My name is Dr. Piyush Oja. This video that we have just recorded yesterday is just to show how important the role of closure device in any therapeutic procedure is. I'm sure there are a lot of animated videos which are available online, but this video shows what are the steps we should follow and how effective it is, as you will see it at the end. So usually we use 8 French short sheet and most of the therapeutic procedures. I'll just play the video and I'll just cover the steps that we are doing. So as you can see, this is the 8 French short sheet. You can use any wire or the wire, usually the short wire that comes with the sheet. We usually use 035 wire to pass through. We usually take it high up, simultaneously looking at the fluoro. I'm sorry for the motion because one of our colleagues, anesthetist, was recording the video. Now what we are doing is we are trying to remove the sheath. So we press our hand, the groin, and we are slowly and gently removing the sheath, keeping the wire in position. Once it's out, we usually moist the entire wire with normal saline. Now the device has two parts. First is the perclosure device, and then there is the trimmer or the suture cutter. One of the assistant or the second person usually is inserting the device through the guide wire. You slowly advance it to the groin, and then there is a marker. If you can see, there is a white marker. Once it's inside, you ask the person assisting to remove the wire. So now we are inside, the wire is removed, and now you gradually advance the device until you start seeing a pulsating blood flow at the guide wire exit port. We are advancing, and now you can see a pulsating flow. That's the moment when you stabilize, you hold it firmly, and then you pull the lever. One. After pulling, that's when the pulsating flow stops, and that's when your distal end is at the anterior wall of the vessel. Now so after that you press the plunger. Number 3, you take out the plunger, and in a violin shape you cut the suture. Now you pull out the device, and as soon as you see the guide wire exit port, you see two sutures. First one is the white colored, and the other one is blue colored. So white, you are not supposed to pull out. You gently hold the blue one. We are holding it. And then you pull out the device. So I'm keeping a firm pull on the blue wire. Now we are taking the cutter through the blue wire. We are introducing the cutter, and now keeping it firm, we are pulling the white suture. Once we are sure we have pulled it firmly, and now you can see there is no oozing. Now you hold both the sutures, take the cutter inside, and you cut the suture. That's all. Thank you.
It's a simple device, and the advantage is it's a suture base. So you are not leaving a plug or a metallic print like an angio-seal where you can compromise, and especially all these patients will be atherosclerotic. So they will anyway have plaques there. So if you put a foreign device, you may actually compromise the circulation. So it's better to use this suture based device, and you can re-puncture them n number of times. It's impossible for you to actually hit that suture even if you do it like 100 times. So this is what we use for almost every neurointervention what we do these days. So we close with a suture, and it's easy to manage. So that's all for the theory part. And if you are interested, there are flow models here, there are suture models here. You can try your hand out, practice. So Sumit is there from Abbott to help you out, and Medtronic team is here, so with their simulators, and they can assist you, help you. You can have your own fun time with the devices. If you have any questions, please address us. We are here to answer them. Okay? All right. Your theory session is over.